say start with our webinar, and all participants, I wish you to enjoy the webinar and Michael's presentation. Thank you very much, and I'm sure Michael will tell a little bit more about himself during the presentation. Thanks. Michael, the screen is yours.
Well, thank you, Matej, and it's my pleasure to join all of you. I wish I could do it in Slovenia, one of the places I have not been in the world. Hope I can make it there at some point. And several weeks ago, Matej contacted me and asked me to talk about optimal health. And this is something that I've been working on for many years, actually several decades. And I told him, well, I would be willing to talk about it, but only in the context of what I'm focusing on now, which is creating ecosystems for healthy lifestyles, and three of the pillars, delivering a therapeutic dose of an intervention, the AMSO framework, this is a framework I developed, I'll describe in more detail, and what I call the resources benefits matrix analysis, which is necessary for pulling in all the critical resources necessary to deliver a therapeutic dose. Now, this is the definition that Matej saw several weeks ago or several months ago. Optimal health is a dynamic balance of physical, emotional, social, spiritual, and intellectual health. And this is part of a definition of health promotion that I wrote in 2009. And I won't go through the rest of the details of that definition. But this is really what caught his eye. You notice I call this definition 2.0. So this wasn't the first definition of health promotion or of optimal health. And the question about can we put forward this idea of optimal health, the answer is dependent in part on the evolution of this question. How do people view their own health, and how do scientists, policymakers view health? And I assume that that's what most of you are. I don't know if you like this idea of optimal health. I don't know if you embrace it as something that you'll advocate for. And we're dependent on both how people view their own health and how you view health as well. And a little bit of background in my field, this is the illness wellness continuum that was developed by John Travis. He published this in 1975, and I've been working in this field since about that time. I was actually just graduating from college when he developed this. And his idea was that typically medical care focused on preventing premature death. And they tried, doctors, clinicians, health systems tried to push people away from premature death to a neutral point of no discernible illness, but also no discernible wellness. And he said, we really need to push further along toward this idea of optimal wellness or optimal health. And I basically bought into this idea, and I presented this many times, and much of our field in the United States did. And by the way, I apologize, I'm going to be presenting an American perspective. And Matej asked me, he said, Michael, really try to think of our perspective. I said, I don't know enough about your culture to do that. And I hope at the discussion, we'll have 3 points for discussion. I hope you challenge me on that perspective. And I know that when I travel around the world and I see how other nations, how other cultures approach these issues, it actually helps me learn about what I'm doing in the United States, because I see cultural differences that I didn't see before I experienced those cultures. So please challenge me on all of those points. And on this particular continuum, one of my colleagues, Noreen Clark, she was the dean of the Public Health School of Michigan, she said, Michael, there's no continuum. It's 2 different dimensions. So I thought about that, and I thought, there really are 2 different dimensions. There's an illness dimension and a wellness dimension. And optimal health is where we have a state of 0 illness, but also a high level of wellness. And that's how I've been thinking about that since that time. I published this in 1995. And on the specific topic of optimal health, physical health has really been the center of the work that we've done. in the United States, and we've been focusing on helping people manage weight, eat right, avoiding drugs and tobacco, being physically active, getting medical self-care when necessary. And I understand from Matej, that's really driving the work that you're doing in Slovenia and in most parts of Europe. And one of the things I did, I started the American Journal of Health Promotion in 1986. You might know it was the first peer-reviewed journal on the science of lifestyle change. And I focused on this definition of health promotion really to drive the editorial content for our journal. My goal wasn't to come up with a new concept, but it was really to help me figure out which kind of editors and reviewers did we need to recruit, how do we need to structure the journal. And physical health was definitely at the core. But as I thought about this more, I realized, there's really much more than physical health. And I realized that physical health is really what attracts most people. It's what the traditional medicine focus on, understands, knows how to measure. And but I also realized we needed more dimensions. Emotional health. In the United States, we think of that as stress management, positive psychology, EAP, which is employee assistance programs. Also social dimensions of health, developing nurturing relationships, good parenting skills, communication skills, social norms that really support healthy lifestyle, and social support for people when they need help, intellectual health. And we think of this in a work setting, certainly growing in your job, but also cultural pursuits, hobbies, acquiring new knowledge, being a student forever, mentoring others in a work setting, tuition reimbursement, and spiritual health, which is kind of difficult in most workplaces in the United States. So we speak more broadly. Religiosity is part of it for some people, but it's difficult to speak about in most settings. But you can always talk about love, hope, peace, charity, sense of purpose in life. And what drives the program? What's the focus? And I realized that it really needs to be different for each person, each organization, based on their priorities. So physical health is what we've started with, and that's a good entry place for many people. But if someone's life is driven by their religiosity or their integrity, they might really enter with this spiritual sphere. Or if someone is raising a new family and that's all they can think about, the social might attract them. If they're struggling with an emotional problem, that might attract them. If they're really career focused or school focused, the intellectual might attract them. But in each case, we try to draw them into the other dimensions by helping them understand how enhancing those dimensions can actually help them achieve their core goal, which might be physical health or any of the other areas. Also important is what's important to the sponsor organization. And you really have to be very conscious of that. Now, this definition I shared with you was actually the fourth iteration of our definition of health promotion. I won't read any of these, but the first one was in 1986 when we started the journal. And this idea of optimal health wasn't mine. The World Health Organization, when they established their constitution in the 1940s, they defined health as a state of complete physical, mental, social well-being, and not merely the absence of disease. The National Wellness Institute, Bill Hetler, developed a model that his model had 6 dimensions. And the extra one was occupational. So the model that I articulated was really his model without the occupational. He had the occupational because he was the director of student health at University of Wisconsin-Stevens Point, and he was thinking about students. And indeed, the YMCA, their definition is to put Christian principles into practice through programs that build healthy spirit, mind, and body for all. So the definition I put forward wasn't to come up with a new idea, but it was really to drive the editorial content of our journal. I think some of the later iterations that I did in subsequent years, it did add to the concept. So I'll come back to this idea of optimal health later. I know this is what Matej was most interested in, but I want to put it in the context of other work that I'm doing. So the discussion that we'll have today will be starting with the problem that we see in the United States and certainly in most nations of the world, and that's the impact of lifestyle on health and medical costs. And I'll do this quickly. This has been where I've been focusing many decades of my career, and there's hundreds of delightful studies I could share, but just going to share a few and share those very quickly. And then after that, we'll pause and we can have some discussion. And then I'll focus on a proposed solution. And that's really this idea of lifestyle medicine. I'll do that quickly. And then a new approach that I've been advocating for the past few years of creating ecosystems for healthy lifestyles. Pause again after that one. And then from concept to reality, which talks a little bit about my efforts to try to make this a reality, this idea of ecosystems for healthy lifestyle, including one failure. And then with whatever time we'll have left, we'll have a discussion. So the problem, our toxic lifestyle habits are killing us and making us go broke. And I think this is familiar to all of you. These are the leading cause of death in the United States from 2015 to 2020. And we see that COVID reared its ugly head starting in 2020 as the number 3 cause of death in the United States. And the US has handled this worse than any other nation in the world. But if you look through these causes of death, you can see that at least 7, including COVID, have lifestyle as either a primary or a secondary cause. And the biggest culprits are tobacco, physical inactivity, and poor nutrition. And we have very similar cause of death in most of the developed nations of the world. Not new, that's not news to any of us. We have fabulous research supporting the link between tobacco use and health. And this is my favorite study by Sir Richard Dahl of England, where he basically followed all the doctors in the UK from 1900 to 1930. And he determined overall that basically if you smoke, you're going to die 10 years early. He also determined that for every age group, the death rate was double for smokers and non-smokers. And we've known, kills about 500,000 people every year in the United States, damages virtually every organ of the body. But the good news is we know that if you quit smoking, you can gain back most of those 10 years. And I would love to take time to talk about each of these studies, but I'm just going to run through them. This is a conceptual representation by Dr. Holt at CDC, our Centers for Disease Control and Prevention in the United States. And he basically plotted the risk of disease with activity and showed that for many diseases that are primary cause of death in the United States, as the level of activity increases, the level of risk goes down. The exception being musculoskeletal injuries, where people overdo it and they get injured. And stroke too, where they overdo it and get injured. Actually, osteoporosis. So the general idea is moderate activity is fabulous, and too much activity can sometimes injure you. In nutrition, one of the studies I like the best was done by Kantz and published 20 years ago in JAMA, where she looked at the quality of diet measured by a questionnaire for more than 42,000 people. And she followed this as a study that went for about 14 years. And for all deaths, she found that the highest quality diets had the lowest death rate. And as the quality of diet got worse, the death rate went up. It was true for all deaths, cancer, heart disease, stroke. In the United States, we estimate that about 300,000 annual premature deaths are caused by poor diet and inactivity. Actually, this number is a little bit old. I think we're pushing it up more to the 400,000 level. Regardless of the precise number, these are huge causes of death. Now, this graph is from a research center that I ran at the University of Michigan. It was conducted by the founder, not by me, D. Eddington. And he published this in 2001, where he looked at the medical care costs per year that were caused or that were experienced by people based on age group. And as you might expect, as people got older, their annual medical care costs went up. But what was very interesting is as their number of risks went up, their costs went up as well. And a risk might be, for example, being overweight or being sedentary or using tobacco or not wearing a seatbelt. And he found that and they're basically groupings, but basically the difference between having low risks, 0, 1, or 2 risks, compared to 5 or more risks, the cost increases were so significant. Look at this, for someone who's 75 with low risks, their annual medical care costs are about the same as people 35 to 44 with 5 or more risks. So just adding those 3 additional risks aged a person from a perspective of costs about 30 to 40 years. And by the way, this particular study was with more than 400,000 people. It was from contracts we held with large companies like General Motors and other companies where we actually had all of their medical care claims for, in some cases, decades of time. And this was the first study that really put this data out there, but it's been replicated several times in the United States. We find the same trend. If you look broader, for example, at the medical level, we estimate that 75% of all spending is tied to chronic disease, and lifestyle is a huge cause of these chronic diseases. For our Medicaid system, which is for people with low incomes in the United States, 83% of costs are related to chronic disease. For Medicare, which is for people over age 65, 96% of the cost. So this is a problem that affects individuals in terms of their own health, but also anybody who's paying for the medical care. And that is what has supported our field in the United States, mainly employers trying to reduce their medical spending by improving healthy lifestyle. And this is a look at the average medical costs in the United States. The data is a little bit old, but the trend just keeps getting bigger and bigger, where this is the cost for single coverage. A couple of years ago, it was about $7,000 per person in the United States. For a family, almost $20,000, and it has passed $20,000. And it's a huge burden for employers and employees who have coverage, and it's crushing for people who don't have employer coverage, especially when you think about the household income is just over $60,000, and they're spending a third of that on medical care, or the average is in any case. And sorry for these data being a little old. Part of it is it takes a while to get accurate data, so we usually get them a couple of years later. In the state of Colorado, where I live, and this is typical for other states, healthcare spending for employees, this is primarily for low-income residents, but also for state employees, 29% of the total budget was for healthcare. Education is 27%. And we see basically the same problem in most states. Education and healthcare are 1 and 2, and they go back and forth. So it's definitely a crisis for the federal government, for employers, and state governments now, the high cost of medical care. The big costs, these are the costs by age. For people who are young and haven't reached middle age, the costs are pretty manageable. But once people get above 65, and these are the people covered by the federal government, the costs are really out of control. Now, I discovered in 2011, the Congressional Budget Office long-term budget outlook reports. This is a report that they prepare every 2 years, and they take a look at what do they think federal spending will be for the next 85 years. And I'd never encountered this in all my education, but I found it in 2011. It's a thick book with lots of data. And what I discovered was this is a plot of spending projected for the next 85 years from that time. And this is a percent of gross domestic product that is projected to be consumed by various big spending items. And for example, this is Social Security at the bottom, and Social Security was projected to go from about 4% to 6% of total gross domestic product in the United States, huge, but not terrifying. But this is the terrifying part. This is federal spending on medical care, projected to go from about 1% to about almost 20% by 2085. And all the other spending in the federal government is this light blue area, not projected to increase, but not really in terms of the percentage, stayed about even. Now, the dotted line is revenue from taxes and fees and other things to the federal government. And it's typically in the United States been around 17 to 19%. And early in our history, or early in my lifetime, the spending was about the same as revenue. We had this unusual time where we actually collected more revenue than we spent. But starting in 2010, it shot up because of a recession. But the projection is to go even higher and higher and higher. So this is what terrified me. Basically, by the end of this period, and really before then, medical spending by the federal government is going to consume 100% of our federal tax revenue. So what happens? I don't know. I think as likely as any outcome is we go bankrupt as a nation. We can talk about those. So that's actually what got me involved in trying to change this at a federal level. If we had a different time, we could talk about my efforts there. But I took a look at the underlying health-related costs of causes of these costs. And lifestyle causes chronic disease, which drives up Medicare costs for our older adults. It also lowers tax revenue because if people aren't working, they're not paying taxes. It drives up Medicaid costs for the people who have low incomes. It also, poverty and inequality, which is the United States is really one of the worst 1 or 2 or 3 in the world in that area, the inequality part of it. If you're not working, you're not paying taxes. Also, that drives up Medicaid costs. Poverty and inequality itself increases chronic diseases, also makes healthy lifestyle more difficult. And we have an aging society, as most nations of the world do. That drives up the number of people covered by Medicare and reduces tax revenues. Aging society also just naturally increases chronic disease unless we can reverse that trend. And it also increases the amount we pay out. Social Security, as you probably know, is the money that's paid to people once they retire if they've been paying in. So really bad situation. I focused on this. This is from an editorial I wrote in 2012. Now, my back of the spreadsheet calculations, and we could spend a lot of time on this, but basically, if improving the health of the population can expand the years of working life by just 5 months, it will reduce our total federal debt in the United States. If we can make it 4.5 years, we can reduce the federal debt by 16%. 9 years, 32%. If we can reduce the annual rate of increase of Medicare by just 0.1 percentage point, it'll reduce our federal debt by 1.5%. If it's 1%, 15%. If it's 2%, 30%. So this is a huge number, isn't it? It's kind of remarkable. And this would require us, my thought is, healthy lifestyle. I've seen studies that I think show we can definitely expand the years of working life by 4.5 years. And I've also seen studies that make me believe that we can reduce Medicare increase by 1 percentage point if we can help people practice healthy lifestyle, which is something I'm not sure that we can do. I don't think we can do it, but that's my dream. So, I've written several papers on this, happy to share them. Very complicated, obviously, but the message I'm conveying here is it makes sense for employers, for state level governments, and for the federal government to be very interested in this. And that's one of the things that led me to working on national policy. For about a decade, I worked on national policy, and we were successful in introducing 3 pieces of legislation that were incorporated into the Obamacare, the Affordable Care Act, when President Obama was in office. So it's time for a pause, and Matej, I'd open it up to you to pose some questions to me or anything you'd like to do. And let's just do this for a couple minutes.
Yeah, there is already a discussion in the Q&A section about mental health. So one of our colleagues from Public Health Institute asked, what about mental health? She misses this in your concept of optimal health. And my colleague from UTRIP Institute answered that it is actually a cross-cutting issue in many dimensions. So where would you put mental health in which box?
Yeah, we think of that in the emotional health area. And, part of what we're going for here is parsimony. Each we could have 20 dimensions, so part of emotional health is mental health, and it's critically important for many reasons. It's a major contributor to most of the lifestyle areas. Mm-hmm. And so in addition to being, a huge problem in and of itself, for example, our estimate is that among people who are smoking, probably over 50% have a diagnosed mental illness. Mm-hmm. So regardless of your target, whether it's physical activity or smoking or drug abuse or eating habits, weight, or just the core quality of life from poor mental health, it's critical. And in the United States, there's always been most employee assistance, EAP, is one of the programs that really has been in place in most employers in the United States, even before we talked about health promotion. And the idea there is to help people with mental illnesses, usually to help them deal with an acute problem and then refer them into more extensive care. But it's been neglected, definitely, and it's really become very clear as a problem during COVID. Mm-hmm. And so absolutely a critical area to focus on, and we do focus on it within the context of emotional health.
Okay, so it's mostly in the emotional box of the optimal health concept. Okay, there is another question in Q&A from Movendi International organization. They were missing alcohol as one of the main risk factors you mentioned. Have you been looking at it too?
Yeah, alcohol is the broad category is substance abuse. So alcohol abuse, tobacco abuse, other drugs, and it's it's a huge. I'm not sure exactly how to focus on the answer there, Matej, but it's a critical problem, and it's a core component of all the programs I've been involved in.
Yeah.
To give you an example, like at the Cleveland Clinic, where I'll talk about later, we, in the smoking cessation area, our standard approach, basically this was true for all of the toxic substance abuse. That's how we talked about it. And we would have a clinician, nurse practitioner, meet with anyone who's interested. And then there would be a cognitive component and a medical component. And the cognitive component could be as simple as a brochure and as extensive as actually inpatient psychiatric care. Mm-hmm. And then everything in between. There were programs, computer platforms, there were group discussions, there was individual counseling, all the way through admission to a mental health program, and then a whole range of medication support. So I think that's actually one of the areas where the alignment between sort of the lifestyle medicine approach or the health promotion approach is most closely aligned with traditional medical care. And some organizations have done a great job. Cleveland Clinic was one of those.
Yeah, great. I'm sure there will be more questions in chat or Q&A, so please continue with your presentation.
Good. So the solution, our proposed solution, is to harness the power of lifestyle as medicine. And we know it works, but we know that few people have access. So the way I like to think about this is that lifestyle can reshuffle the genetic deck by changing the expression of our genes. And it looks something like this. Genes lead to disease sometimes. And when that happens, we have premature death. But lifestyle can actually impact disease directly. Disease can also impact lifestyle. If you're sick, it's hard for you to practice a healthy lifestyle. But the genes, the lifestyle can actually change our genes both directly and by changing the way that the genes result or don't result in disease. And this in turn reduces premature death. So our estimates, and this is from the EPIC Potsdam study, is that lifestyle can actually reduce overall disease prevalence by up to 78% in the United States for all diseases, and for diabetes, about 93%. And by lifestyle, we're talking about tobacco, diet, physical activity, and obesity. Now, we could spend an hour just talking about this slide and the several studies in this area, but I'm trying to make the connection for traditional medical people that lifestyle actually is medicine that can be as impactful as every type of medicine they're already practicing. So what is healthy lifestyle? You know, this is a list that I don't think most people would disagree with. It's about being active, eating nutritious food, avoiding all those toxins, getting enough sleep, cultivating meaningful relationships, managing emotions, which is it's certainly mental health is part of it. And I realize it's not a very complete description of the whole mental health area. And then medical care when needed. Now, there have been thousands of documented successes that show that lifestyle medicine can improve health and save money if it's done right, for individuals, for employers, for communities, and even national campaigns. And I'll share a few examples. This is from Dean Ornish's work, which you're probably very familiar with. I was fortunate to meet Dean more than 30 years ago. We both lived in the Bay Area in San Francisco while he was doing some of this early work. And this is from his one of his first studies, where he took patients who had early heart disease, but were not yet on lipid drugs. He randomized them into a treatment and control group. And then he had a program that started with 1 year and went to 5 years. It was exercise, stress management, low-fat vegetarian diet, smoke cessation, and social support. And he published his first results in Lancet in 1990. And he found that with PET scans, he found that while typical medical care showed improvements of just over half of the people in the usual care group, in the lifestyle medicine group, 99% showed some improvements in PET scans. And that was published 5 years later. And this study has, last time I looked, had more than 3,000 citations. It had been replicated in large and small groups. And it's now covered by our Medicare program for older adults, as well as some private insurance companies are paying for it as well. Another one that you're probably familiar with is diabetes prevention, where the in this original study published in New England Journal of Medicine in 2002, 3,200 people who were pre-diabetic were randomly assigned to placebo pill, metformin, or lifestyle modification. And there were great results in onset of diabetes 3 years later from metformin. And that was the original headline. But when the people took a close look, they realized that actually lifestyle worked even better, with over half, 58% reduction in onset of diabetes. And for older people, 71% reduction. Now this has been studied many times. There's been 14,000 citations to this and follow-up studies. And they found that the lifestyle was still superior to metformin after 15 years. It's been replicated in large and small groups. It too is covered by Medicare. because it improves health and reduces costs for Medicare. Now, at the Cleveland Clinic, I launched the Healthy Lifestyle Program back in 2005. And Cleveland Clinic is a huge organization. It has 220 care locations, 22 hospitals, over 50,000 employees, and over 100,000 covered lives. That means, like, for example, the spouses and children. And when I wrote this up, medical claims were about $450 million per year. And the Cleveland Clinic program had four major components: enhancing awareness about the link between lifestyle and health, motivation to get people to decide to make a change in their healthy lifestyle, skill building, focusing on reducing chronic diseases, and enhancing lifestyle in the most common areas. And here another, we could talk about this for a long time. Opportunity was critical. So this is the model I developed, the awareness, motivation, skills, and opportunity model. I'll come back to that in a little time. But we had very strong support from our CEO. We had a long, decades-long culture of tobacco activism, including helping to pass state-level laws requiring workplaces to be smoke-free. Our primary physicians were actively engaged, and we had more than 2,000 physicians at the Cleveland Clinic. And not sure you know the clinic, but it's usually ranked the number 2 or 3 hospital in the United States, or 4 or 5. And usually it's been number 1 in heart care for several decades. Nutritional foods in restaurants, free fitness centers. And we focused on outcomes, 6 biometrics: blood pressure, obesity, hemoglobin A1C, asthma, and unmanaged stress. Protein eating is a measure of tobacco use, and LDL cholesterol were the normal biometrics. And the goal was to push people to get 6 normal values, and then also see primary physicians regularly and be up to date on immunizations. And when I wrote this up a couple of years ago, 69% of all employees and spouses had enrolled in this program where they said, I want to try to do this. And by 2018, 43% of all employees and spouses had achieved this goal of 6 normal values and seeing their primary physicians and being up to date on immunizations, or really close by definable protocols. The employees actually were rewarded. They saved as a group $50 million in premiums, and that worked out to $600 or $1,400 per year. It was $600 if they said, I want to try, and it was $1,400 if they achieved their goal. Now, for the organization, we were successful in changing the rate of increase of medical care costs. It was increasing at a rate of about more than 7% a year, and it was reduced to around 5% by 2017. And the savings was $261 million from that, from bending that curve. And the number is a lot bigger now, several years later. So, that's probably one of the best outcomes anyone's seen in the United States. But a systematic review by Cyan Baxter and colleagues, it was published in 2014, there were 47 interventions that focused on traditional health promotion programs. 46 out of 47 saved money. 41 out of 47 saved more money than they spent for the programs. And the ROI was more than 2 to 1. So if you do this right, we know that we can save money. And there are thousands of documented successes and thousands of failures that are not documented. And the programs that work, the efforts that work, they work because they deliver a therapeutic dose of best practice strategies. But most efforts by employers or clinicians are too superficial or use ineffective strategies, and we can predict in advance they're going to have no benefit. So the idea of this effort that I launched several years ago was to create ecosystems that inspire, enable, and sustain healthy lifestyle. And there are huge gaps in access at work. And I tried to get a sense of how many people in the United States have access to these types of programs. And I won't go through the details of literature. It's relevant in the United States, probably a little too much detail for this audience, but about 80% of large employers offer health promotions in the United States. And if I have references, they're posted down here. And about 47% of workers say they have access to programs, but only about 13% are comprehensive. And then the estimate is about 7% of workers have access to comprehensive programs. But in small businesses, there's much fewer programs, and maybe 2% of workers in small businesses have access. But we have no idea if spouses have access or children, and half the population in the United States is unemployed. So overall, my best guess is about 3% of the population in the United States has access to lifestyle medicine or health promotion programs that are high enough quality to make a difference. So we really haven't had impact on the organization as a whole. So I see this as one of the most damaging health disparities in the United States. And that was just workplaces. We really have no idea of the access in other settings. So my goal is every place that people work, learn, play, pray, they have access to ecosystems that inspire, enable, and sustain healthy lifestyle. So let's take another pause, Matej, and have some discussion.
Yeah, thank you. Great, great presentation, and really to the point. I see Tanya wants to speak. She raised hand, so I will allow her to ask live question.
Okay. Hello, Tanya.
Tanya, Ritonya, you raised hand, so you can speak. Or was it by mistake? Probably.
Okay.
I suppose. Okay, then we have some. Sorry, it was a mistake. Yeah.
Okay.
So there is also in Q&A, there are two questions. One is probably already from the first part. And a colleague from Serbia is asking, what about new addictions? He means digital media addictions. This is a new.
Yeah, I don't really have any expertise on that, and I do recognize it's a problem. And it's probably the not. I'm just thinking if it's more of I think in terms of the state of the art among lifestyle medicine programs in the United States, there's a recognition of the problem, and I think ways to treat not very well developed yet. I would say that in the United States, the focus is on the main cause of death: heart disease, cancer, diabetes. Those are really the drivers, and addictions, not good, but not something that would typically be focused on. Also, as I reflect on it, most of the programs are in workplaces, and maybe that's a problem that's more common among younger people. But it's not an area that typically I see addressed in lifestyle medicine programs in the United States. Definitely a problem that's recognized, but just really not good approaches. Yeah.
Yeah, there is another question from Slovenian colleague. What about distress as part of lifestyle?
Distress as part of lifestyle? We would think of that in the emotional health area. And certainly, the way that we would typically handle, if by distress you're speaking of an acute problem that needs immediate treatment, the way that would typically be handled is through psychotherapy of some kind, or counselors, depending on the cause of the stress, like grief counselors. And we also recognize it's, if you're talking about acute versus chronic, it would be handled differently. But we certainly recognize that it's an acute problem that causes damage in the immediate, but it also makes it very difficult for someone to practice healthy lifestyle in any of the other areas. And I should say, my expertise is not the specific methods of treatments in any of these areas.
Mm-hmm.
It's more putting the system together and then pulling in the best people to really address each of the areas.
Great, thank you. And time is running really fast, so I would like to ask you to continue with presentation.
Okay, so the approach that I've been advocating is to create ecosystems for healthy lifestyles. So I put together a group here in Colorado to try to do this at a statewide level several years ago. And the prerequisites we set in advance to be effective, we had to deliver a therapeutic dose of evidence-based approaches. It had to be fiscally self-sustaining, and it had to be scalable to address state and national level problems. So what's a therapeutic dose? It's exposure that's sufficient to make an impact, sufficient intensity, frequency, time lapse over time, and it has to be ubiquitous. It has to be every place. And we had to move beyond this idea of creating programs to creating entire ecosystems. So what's an ecosystem? It's people really interacting with complex environments. So we wanted to have all of these ecosystems shown here to influence people to practice healthy lifestyle, make them aware, give them the skills, help motivate them, and most important, provide that opportunity to practice healthy lifestyles. So this idea of ecosystem, let's just take obesity as an example of the impact. So in the United States, we've engineered activity out of daily life on every time we have the opportunity, whether it's, instead of walking down the hall to talk to somebody, you send them a text. We've done that in workplaces, in home lives. I know I've seen kids sitting next to each other, really 10 feet apart, and they're texting instead of talking in person. With food, we've engineered it to be addictive, low price, packed with calories. Nutrients aren't a priority for the agribusiness industry. So how does that impact lifestyle? Physical activity is much lower in the United States than it used to be, just as part of daily life. The food that's consumed is high calorie, low nutrient. Now, how has that impacted health? Obesity causes diabetes, heart disease, stroke, some cancers, gallbladder disease, osteoarthritis, depression, and anxiety. It's possible that lifestyle can be the only antidote to a toxic ecosystem, but it's very difficult. And by that, I mean, a highly disciplined, highly skilled person can fight against their environment and practice a healthy lifestyle despite the challenges, but it's very difficult for most people. So let's make this tangible. So this is a plot of obesity in the United States starting in 1994 and diabetes. And basically, the darker the colors, the higher the level of the obesity or diabetes. And what we typically find is that increases in obesity are followed by increases in diabetes, but with about a 2-year lag. So let's just take a look at what's happened in the US in recent years. It's really scary. Diabetes is a very common disease in the United States, and I've seen estimates of half of people having diabetes or pre-diabetes in the United States. So what is a healthy ecosystem? What's it look like? And just some quick examples from workplace, hospitals, and school. But I want to stress, education is not enough. This is the AMSO framework, the Awareness, Motivation, Skills, and Opportunity Framework, is a framework I developed. I first published in 2005. And the idea is we have to help people be aware of the link between healthy lifestyle and health outcomes. And we used to believe, this is enough, we used to believe if we just educate people, people are smart, they're rational, they make good decisions. But what we're finding is maybe only 5% of the change comes from that awareness. Critically important is motivation. And by motivation, we're talking about having motivation to practice a healthy lifestyle to achieve outcomes. And this might be, the key is you have to find out what's important to a person. For some people, having a little extra money or being part of a game is a motivator, and they'll actually join because of the financial reward. But we usually find more often that it needs to be something intrinsic. It might be a parent might say, I want to be a good role model for my kids, so I'm going to practice healthy lifestyle. Or a grandparent might say, I want to be live so I can play with my grandchildren. It might be, I've heard even faith. Someone says, I was given the gift of this body by my God, and I need to take care of it. And I need to be a good witness for other people. Some people like me, I'm a health nut. I want to be healthy because I want to be healthy because I want to be healthy. But you have to find out what motivates a person and help them understand the link between what's important to them and healthy lifestyle. That's about 30% of the challenge. Skills, once they're motivated, is knowing how to quit smoking, a habit they've practiced for decades and they're physically addicted to, or start exercising after they've been sedentary for decades. It's kind of like learning a new language. And this is actually where we've seen great progress in the United States. Opportunity is the most important thing. Having the opportunity to be physically active in a safe environment, having the time to do it, having access to food that's nutritious and not so expensive and is in your neighborhood. So this is the overall formula, and it has to all be delivered at a therapeutic dose. So in a workplace, leadership and coworker support is very important. Skills training in all these areas, opportunities to practice healthy lifestyles, and what we've been pushing is investing in community health, because you can't reach your employees 24 hours a day. You can't reach the spouses and the kids. So we're advocating for investing in the community in little cash dollars, especially in schools, to reach the children. Now, in a hospital, it's really very much the same. Hospitals are the biggest employers in most towns in the United States. And so they need to be a healthy workplace. But in addition to reaching the employees, they need to integrate lifestyle medicine into patient care and also into the funding that they provide to the community. And in the United States, if you're a nonprofit hospital, you're obligated to actually invest in the health of your local community. Now, in school systems, it's really very similar, where you're focusing, you have teachers that you want to influence, but also kids. So the teachers become role models for the kids. And we're trying to, for example, avoid students from starting to smoke. We also need to help them feel safe and valued and learn in a nurturing environment. And here's where we come back again to the whole idea of the dimensions of optimal health. It's really parents want to influence their social health, their intellectual health, their emotional health, and spiritual health, even though physical might be at the core. Now, I think I'm going to pass, I'm going to go very fast through this part, Matej, because it's kind of complicated. But typically, foundations fund programs, governments fund programs, funding goes away, everything goes away. Our aspiration was to get foundation for seed funding, but mobilize other resources to multiply the investment of the foundation's priorities and even repay the foundations, the seed money. And we had to invest newly mobilized organizations. So, and our vision was we would stimulate economic growth through investments in creating these healthy ecosystems, which would actually produce tax revenues at the state and federal level. And I did write a paper that people can read about those details. So because of the time, I'm not going to describe in detail the mobilizing organization that we wanted to create. But I will say that the main element of this organization was the staff were all mobilizers. People who would mobilize celebrities, employers, health plans, schools, faith communities, local governments, some policy mobilization, some focus on the technical expertise. But we found that that technical expertise is out there already. We could draw on the private sector for it, and they would make money. And the key, and I want to spend some time on this, we have to mobilize other resources. And to do this, we have to decide, we have to figure out who has the resources and who benefits by mobilizing them. So in this matrix, our goal was to have $250 per person per year spent on these efforts. And by the way, that's the number I determined you need to spend to deliver the therapeutic dose in workplace programs. That worked out to about 1.4 billion a year for the 5.5 million Coloradans. If we did this for the whole United States, it's about $80 billion a year. And so this is what we came up with. Basically, large employers, they have the most resources in terms of the money. They are already spending more than $7,000 a year for every single employee on medical care costs now. The $80 billion that we need represents just 1/3 of 1% of the cash that they have on hand. They also benefit if their employees are healthy because they can possibly reduce this huge sum of money they're spending already, and they have more productive employees. It's also a great way to attract and retain the most talented people. Health plans have the resources, but in the United States, they don't save money when the costs go down. They're basically like bookies. They get a percentage typically of the amount that's spent. And we don't expect small employers to be able to support it much. Medicare has the resources and benefits. If they actually reduce spending, the spending goes back in the bank. Hospitals are critical, but in other ways. And this is a plot of how I actually saw the money flowing in the state of Colorado, but too much detail to go through. How to become fiscally sustainable. We saw employers, health plan, hospitals, Medicare, and individuals funding the creations of those healthy ecosystems based on that resource benefits matrix analysis, not foundations or governments. We also envisioned a buyer's coalition that would capture 1% of the flow of new investments between employers and all those other organizations. We'd capture 1% to support the core mobilizing organization. And it's not just financial resources. You need to engage people and who is best able to do this. And here's our plot of who's best. Again, large employers, small employers, and schools. Who has the intellectual capital, the health promotion providers, and certainly other non-traditional players like architects, city planners, state and local governments, hospitals, clinics, and health plans, policy authority, state and local governments. So that's what is a little different about our approach. It's a new idea for most people in healthcare, but I think that's where we need to go if we want to raise all the resources we need to deliver that therapeutic dose. Now, is it possible, Mate, to advance this idea of optimal health? And I think there's two things at least we have to think of. What does the target population that you're targeting want? What will engage them? Is this idea of optimal health something that will really engage them? Or is it solving a specific health problem? And similarly, what about the gatekeepers? The funding gatekeepers, the social capital gatekeepers, the content experts, the policy gatekeepers. And you have to answer that question. In my experience, it's been difficult to sell that idea or get people excited about that idea of optimal health. For example, among employers, religious employers, they really do gravitate toward that idea of spiritual health. But most employers are trying to reduce the medical care costs and have a more productive workforce. So they focus on the physical side. But what we've seen in evolution, in terms of the name, what people call these efforts, the scope of interventions, the outcomes, the approach they take. For example, health promotion is a term that was very common among scientists and the federal government when I got involved in the 70s. Wellness was more used by people on the street, the average person. Lifestyle medicine is a term that I'm really getting behind now because the focus I'm having in hospitals and because it's conveys some credibility. But employers, they're using the term well-being because they're discovering that really engages the typical employee. The employee doesn't want to be thought of as someone to reduce their health risk factors. That's kind of offensive and self-serving. They are gravitating toward this term of well-being in the United States, and it's going to be very different in every culture. So, Matej, I think this is a good time to pause, and then if we have time after this, I'll talk about two efforts I've tried, one that's working well, one didn't work well, to implement this idea.
Yeah, thank you very much. I already announced that we could prolong the webinar for a few minutes, especially because there was a few questions and comments in Q&A. So that's the reason why we should continue until the end of your presentation.
Okay.
Maybe just as a interesting comment in the Q&A about if I think this is a kind of question mark, if stress management is really a part of lifestyle. So that's something which is here in the Q&A as a
yeah. So I would say absolutely it is. And for example, the proactive way that is part of lifestyle is what you do in your daily life to relax, to manage your own stress, whether that's something like yoga or meditation or cognitive restructuring of problems or exercise. And it's a treatment as well, for people who are suffering from mental health or just stresses of daily life, teaching them skills in each of those areas. So stress management, we definitely see it as part of a person's normal daily lifestyle, but it's also a treatment that has shown very effective outcomes in many studies. One of the areas that's studied most commonly in the United States, or one of the greatest number of areas of study in the United States.
Yeah, I agree completely. Yeah. So yeah, please continue with the last part of the presentation. Okay. Hopefully at the end, we will still have enough participants to have some more discussions.
Okay, good. So our group in Colorado, when I moved to Colorado, the governor had the goal of creating the healthiest state in the nation, which is part of the reason that I was inspired to try to launch this in Colorado. And I contacted his office and he said, we're absolutely delighted. So we spent about a year planning for this. And we put together a pretty good plan on how to reach every single person in the state of Colorado. And we imagined a pilot in which we would test. We know that this works for individuals. We know it works for employers, but we asked ourselves, can we make this for an entire community or sector of Colorado? And if the pilot showed us yes, we could do it, then we had a plan to expand to all sectors in all places of Colorado. And based on our resource benefit matrix analysis, we said we'd focus our pilot on the 46 hospitals in the 7 counties around Denver, Colorado, where I live. And our goal was to create a collaborative learning community among these hospitals of the most effective strategies to integrate lifestyle medicine into employee health, patient care, and community support. So that got back to our resource matrix benefit analysis. We felt we could reach the greatest number of people, employees, patients, and the communities around these hospitals by focusing on hospitals. They also, they're credible health messengers, and they've got the most of the critical capital needed to be successful. It's also my history. I've done this in 4 separate hospitals in the United States. So our timing was to confirm the hospitals and raise the funds by the 3rd quarter of 2020, launch in the 4th quarter, and then expand over time. Bottom line, we didn't raise all the money that we needed to do this, and we had decided in advance we weren't going to try to do it on the shoestring. So we shifted to working with another organization, the American College of Lifestyle Medicine. This is the fastest growing medical society in the United States. It's actually grown to over 7,000 members. It was just founded 16 years ago. And most of the members are clinicians, doctors, and some nurses. And their vision is a world wherein lifestyle medicine is the foundation of a transformed, sustainable system of healthcare. And the mission is advancing evidence-based lifestyle medicine as a value-based specialty that transforms, redefines, and sustains health and healthcare by treating, reversing, and preventing non-communicable chronic diseases. So we have worked with them to develop a health systems council. It has more than 40 members now. These are the founding members. And the range is among the best, for example, Massachusetts General Hospital to small community hospitals, research hospitals, community hospitals, places like Kaiser, which are health management organizations. And our advisory board is composed of some of the most talented people in the field in the United States. And our aspirational goal is to integrate a therapeutic dose of lifestyle medicine into employee health, patient care, and community benefit. And we call this T-dose, the therapeutic dose, and EPIC for employees, patients, and community in a critical mass of health systems in the United States. And while we do this, embedding and advancing health equity to be a core element of all these efforts. Now, that's important every place in the world, but in the United States, because we have the highest income inequality in the United States, and people who don't have the resources have the highest healthcare problems. And we've really confirmed that it's because of systematic racism. And we have to, any health effort trying to improve the health of this nation has to address that problem head on. That's our aspirational goal. Our operational goal is to help health systems get closer and closer to integrating a therapeutic dose of lifestyle medicine into those 3 areas, employee health, patient care, and community health, while embedding and advancing health equity in all those efforts, but also recognizing the starting point for each of these hospitals. They're all at different places. Some have very sophisticated programs, others don't. And their health and organizational goals. That's critical because if it serves their goals, it'll stick. If it doesn't, it won't. And also recognizing the state of the art and the science in each of the areas of intervention. So we have finished building our team to do this. And we are in the process now of building and enhancing the resources necessary to do it in all those 3 areas. So in patient care, the American College of Lifestyle Medicine has already developed curriculum to train clinicians in all aspects of lifestyle medicine, in the form of certainly continuing medical education programs, but even full residency programs, and has developed board level certification. So this is the area that the most progress has been made. The area that we're focusing on now in terms of employee health is taking what's been learned in employers across the country and creating a resource that hospitals can draw on to make the best programs in for their employees. So this will take at least another year to do this. But the whole key is we want to motivate them to do a therapeutic dose of these efforts. Virtually none of them does that now. If they don't have a therapeutic dose, it's really virtually worthless. And then to develop protocols on how hospitals can build lifestyle medicine into their community benefit programs. And this is, it's almost $100 billion that's being spent by hospitals in this area now. And it's money that just goes out year after year. And we want to make sure that lifestyle medicine is part of it. So Matej, that's the end of my formal presentation. Happy to have discussion. I know we've stayed on about 10 minutes longer than we had anticipated. And I appreciate
it. The vast majority of attendees are still with us. So
right.
It's interesting enough to keep them motivated for the webinar. And there is a discussion in the Q&A. But I would first comment by myself. I checked yesterday the most recent OECD numbers and statistics about the health spending in prevention, and the numbers are shocking because only 2.8% of health spending goes to prevention.
Yep.
And this is pretty much around the average in United States and in Slovenia. So this is really actually a shocking information. And also here, one colleague is asking, why do you think there is so little interest from the government and politicians to change the environment? The numbers clearly show the benefits of healthy population, but instead of general health is turning worse during the years, and the map of obesity and diabetes is shocking. So this is something which is shocking for me as well, why there is so little interest in investing in health.
Well, it's interesting. That number shocked me the first time I heard it about 30 years ago. It's been very small in the United States for a long time. And I think, the reasons, like answering the reason why is it so low versus how do you change it, I think are two different questions. And I think it's basically, I focus more on how do you change it. And that number, most of these efforts, so for example, within Medicare, which is for our older adults, if you look at what's covered in prevention there, screening programs are covered, programs like heart disease reversal are covered, the diabetes prevention and reversal are covered, but the number of clinical organizations that are able to provide those is really very small. Mm-hmm. We see that the kind of work that I'm talking about, work by employers in lifestyle medicine or health promotion and wellness, it's not covered in that 1% bill. And we've seen among employers, that field has grown to, I'm just guessing here because it's not measured by very good methods, but it's basically overall we're spending between $3 and $4 trillion a year in the United States on medical care. And the weight control industry is about a $50 billion industry. The workplace health promotion field is maybe a $20 billion industry. Mm-hmm. So we're approaching in these non-government programs, somewhere in the $100 billion range, which is a tiny, even though this is a tiny percent. So we're trying to make that argument. The argument has been made well already with employers that this is a good way to reduce their medical care costs and make their employees more productive. We're trying to make the argument with state governments. It's difficult to do that. We've been trying for decades to make the argument with in terms of the federal government, and it's really very difficult. And I think it really comes down to money. There's a huge flow of dollars flowing to clinicians and to industries, and they want to keep that money flowing.
Yeah, and I think also that a huge part of this problem or issue is because unhealthy industries are involved in lobbying, and they want to
Absolutely.
keep their profits, and they lobby at the political level quite a lot.
Yeah, for example, like when I spent about a decade trying to advance this policy in DC, and we made some really good progress because we're a white glove topic. Nobody is really against it. But during that time, I got to know a lot of the other lobbyists, and for the pharmaceutical industry, this one organization, they have full-time lobbyists for every single member of Congress. And we haven't been able, we're not even able to persuade our federal government to negotiate drug prices for Medicare. Medicare is the biggest purchaser of drugs, medications, but Medicare pays more for medications than a typical employer because of the influence of lobbying. But it's partly, it's largely cultural as well. And it's also ability. The number of organizations that really can provide high quality, evidence-based efforts that deliver a therapeutic dose, it's small, but it's changing. The American College of Lifestyle Medicine is having a significant but small impact on changing the culture of physicians in the United States. And when the Cleveland Clinic has reported its remarkable results, that's making hospitals stand up. So it's partly a culture change. It's complicated. I'm focusing on relatively small portions that I can access. So I'm trying to, and that's a big enough challenge.
To influence federal level.
Pardon?
It's too complex to influence federal level.
Yeah. It depends. Like it wasn't complicated when we tried to do that, from 2000 to 2010, because there was very good bipartisan discussions in DC, and this was a fascinating issue with a good science base. So we were able to go to DC and make develop lots of supporters, but it's dynamic, changes all the time. We can never outcompete anyone. We worked with all the major medical groups and health groups, for example, like American Cancer and Heart, they're totally behind this approach, American Diabetes Association. So it's challenging.
Okay, great. Let us conclude this one with one question or comment. I would say that you mentioned several times a therapeutic dose of best practice strategies.
Right.
And there's a question in the Q&A, what exactly were the most effective strategies to integrate lifestyle medicine to employees in pilot research? Or maybe also in regular practice. So
just a minute. Let me get something. This is a book I wrote. This is the 5th edition, and it's about 2 inches thick. So I think you need to read all 5 editions of this book to answer that question.
Yeah.
I wish there were a simple answer, but we could talk for another hour about that. If you can make the question more precise, I'll attempt to give a quick answer.
No worries. We will share your book with this colleague. We know her, so we will share it with her.
Good.
In the next couple of weeks.
Okay, good.
So, Michael, thank you very much for interesting and very valuable webinar. And I'm pretty sure we will host you also in person in Slovenia in the near future. Just that this pandemic goes away, and we'll start discussing how to bring you to Slovenia one day.
I'll look forward to it.
Thank you very much. And we already exceeded quite a lot the time of this webinar. So thank you very much for participating. And
bye-bye.
Bye. See you soon.
Okay.
Bye.
Bye-bye.